We have 6 talks today, and we're talking about trends in corneal transplantation. I'm pleased to have Professor Mathur with me, who's going to probably introduce the first speaker.
Yeah. So it's my pleasure to introduce Charles McGee. So Professor and Chair of Ophthalmology and Director of New Zealand National Eyes Centre. Really needs no introduction from New Zealand. Welcome to Delhi. And
Thank you.
you'll be talking on international trends in corneal transplantation.
Thank you very much. This is really hopefully just a scene setter for what's to come. I have no financial interest in anything I'll be presenting. So corneal transplantation has evolved enormously after a period of experimentation. It's over 100 years since the first successful transplant was performed. Penetrating keratoplasty was the mainstay of practice for many years, but lamellar surgery has been the big deal for the last 25 years. And now we're moving towards cell-based transplantation. What are the benefits of penetrating keratoplasty? Well, we know it works. In low-risk cases, it works very well. There's no interfaces, and you can get 20/20 vision, though you may need contact lenses. But it's more risky. There are suture-related issues, which are a big problem. There are corticosteroid issues, which are a big problem. And of course, the thing that worries us most is allograft rejection. What's happened globally, I'm going to use some of the American eye bank data. This is from 2023 up to the end of 2022. Obviously, you can see the effect of COVID. COVID had made a big plunge in donors, an enormous plunge in keratoplasty, though it's picked up to almost the same levels. Looking at trends for indications, I'm going to use some New Zealand data because we've been following these for 40 years. If we look at this trend at the first 10 years of this decade, we found that keratoconus was by a very large margin the most important indication. But that is changing. And one of the things which has changed over the years is that ectasias, such as keratoconus, have become less likely to be the number one. And the number one indication is more likely to be repeat corneal transplantations, in part because we've done so many in the past. We're now redoing those. Corneal dystrophies have become very important, mainly because Fuchs, which previously we didn't operate on until it was 2040 or poorer, is now being operated in much earlier levels. So there's some major changes in our data, and that's mimicked in other data from around the world. So we look at the common indications here. This again from the Eye Banks of America. We find that ectasia is now the second most common cause, and that regraft has actually become the more common cause. The other indications are still there, like post-cataract edema and corneal endothelial dystrophies, but those are not usually an indication for penetrating keratoplasty now. Usually endothelial disease is treated by lamellar keratoplasty. What factors have affected this change? Well, one is obviously the uptake of endothelial lamellar keratoplasty has made a big dent. The other thing is that corneal cross-linking has made a very big dent. Corneal cross-linking has been around since the early 2000s, and you would expect it to be about 4 to 8 years before it make a difference to transplantation, because most people are about 8 years from diagnosis to transplantation. There's also improved cataract surgery. We're doing more cataracts than ever, but even though we're doing more cataracts, the surgery we're doing is less likely to cause endothelial failure. If we look at keratoconus, keratoconus is relatively common in New Zealand. It's been the most common indication for the last 40 years. But if we look at when we started doing cross-linking, which was 2007, we started on a big scale in the public system, we've seen a definite drop in the indications. We've also seen that although we still do a large number of penetrating keratoplasties, up to a few years ago, we saw this dramatic merge with the uptake of lamellar surgery downturn in penetrating keratoplasty, so they were almost equal by 2018, and now they are equal. Now, one of the issues with penetrating keratoplasty is rejection. Now, you get it with other techniques, but obviously it's a worry with penetrating keratoplasty. And although keratoconus does well, 90% survival in low-risk cases beyond 10 years, the other cases tend to do really quite badly. And of course, even in keratoconus, it can do badly, and rejection is one of our big risks. And if we look at regraft, which has become the second or first most common indication in most countries, they do very well with PK as a regraft. You'd see that keratoconus and Fuchs do quite well, but the others do very badly. So we need to look at other ways of doing regraft. And of course, a lot of this energy in terms of trying to decrease the risk of rejection has gone into DALK, and we're in a country where DALK is performed to an extremely high standard. This is just an ALK, so this is a partial thickness in someone with an anterior stromal scar. The patient gets good vision at the end of the day. If you do DALK, they'll get even better vision. So DALK and EK are on the rise, but the interesting thing about DALK, if we look at the American data, although endothelial keratoplasty is now twice as common as penetrating keratoplasty, look at the number of anterior lamellar keratoplasties out of more than 45,000. It's actually quite low. Why are we doing them? Well, if you look at the domestic reason, they're mainly done for ectasias, but they're not done anything like as highly as it would be done, say, in New Zealand or elsewhere. Why wouldn't you do deep anterior lamellar keratoplasty? It should be the first choice in keratoconus. Similar vision, similar refractive error. It's technically a bit more difficult. It's harder in some conditions such as eye drops, scarring, neovascularization. And financially, it's not worthwhile in some countries. It may take you longer, and your remuneration will be the same. Not that that should be a driver, but it certainly affects some people. The major advantage, of course, is that you preserve the endothelium, so there's no endothelial rejection. Though some data shows that the risk of failure is about similar, although usually it's rejection which destroys most PKs. So if we look here, this is just an early paper from 2012 showing the differences in terms of risk profile. If we look at the DLK compared to the PK group, overall risks are higher in the PK group. Sutures are in for longer, they have steroids for longer, they have rejection episodes. Obviously, there's no endothelial rejection in DALK, but you can get stromal rejection. In terms of ocular hypertension, DALK is a shorter course of steroids, whereas PK tends to be longer. So again, there's a big difference in ocular hypertension. So although around about 2011 in America, the transition went from penetrating keratoplasty to lamellar, if you look at the bottom line there with the red arrow, the number of DALKs has not really picked up at all. It stayed around about 1,000 or 1,500 at maximum. There's some other things which are happening just now, including CARES, intrastromal lenticule insertion, Bowman's layer transplant. There's very little literature in most of these. I think CARES may be a promising option. I'm not so sure about intrastromal lenticle insertion or Bowman's layer transplant. Was that some warning that I had to finish or someone's phone going off? So if we look at endothelial keratoplasty, changes in indication mean that now DSEC, PK and DMEC are all about 1/3 each. DMEC has not replaced DSEC for a number of reasons. What the advantages? Well, we all know the advantage. It's less invasive, it's less refractive change, shorter steroids, and a lower risk of graft rejection. The main indication for endothelial transplant is Fuchs endothelial dystrophy. If we look at 10-year trends up to 2023, we find that the vast majority of endothelial dystrophies, mainly Fuchs, but we also have an increasing number for repeat corneal transplant. And again, these numbers are just borne out here. The total endothelial procedure is about 30,000, about 15,000 in each group, DMEC versus DSEC. What are the advantages? It's an early paper. Well, the mean survival is reasonable. Graft dislocation or rebubbling is a problem. Primary graft failure was a problem in the early studies. Here's one of mine with the graft sitting in the anterior chamber, not so good. DMEC, these are a couple of videos from Mark Terry at the time. DMEC, apart from the juggling with the unfolding, seemed to be a bit more straightforward. But although the vision might be aligned better, primary failure rate was not insubstantial, and the rebubbling rate was high. So after 5 years, if you look at the study from Price, the survival was about the same. The rejection rate was lower in DMEC, although other studies have shown the rejection rate to be about the same. And the endothelial cell loss is about the same. In the larger study, we see there is better visual acuity, although it's statistically significant. It's about 1 line, and comparable endothelial density, but an increased graft detachment rate for DMEC. What does the Cochrane say about this? It says that DMEC is associated with more surgical complications. The dislocation is 5 times greater. Graft dislocation, as we all know, occurs early, so it might be something we can deal with, but it does involve return to theatre. DMEC may improve better vision, which has been driving it, but we're talking about 1 line, perhaps 2. But one of the summaries here is almost everyone does well, whether they get a DMEC or a DSEC. But DMEC is a faster rehab. What are we doing now? What are the trends? The trends are pre-stripped tissue, pre-stamped tissue, pre-loaded tissue. And if you look in America, 85% of DMEC is preloaded. Obviously, only a small number of DSEC. Most people are not preloading DSEC. So is there an emergent superiority in the world literature? No. In fact, there's a period of equipoise where we're getting more refined indications for DMEC and different indications for DSEC. The future is almost certainly endothelial cultured cells, and the work from Kinoshita and others is proving to be really quite marvelous. But how would I conclude? What are the global trends? Well, penetrating keratoplasty is now falling substantially. It's about 30% or less. DALK is the first choice for keratoconus, but isn't picked up in all the markets. DSEC will continue, I think, for complex high morbidity cases, patients with tubes, patients with previous PKs. DMEC is certainly the first choice for straightforward Fuchs. Lamellar tissue is increasingly prepared for IBANCs, making the whole procedure easier. And keratoplasty numbers continue to increase, but they're not quite back to pre-COVID era, but they're certainly greatly exceeded by the global demand. Thank you very much.
Great. Thanks, Charles. We can take any questions from the floor, Charles? Charles, maybe I'll just ask one question. You know, you showed that curve with a massive reduction, obviously mentioned about COVID, and with the increase in lamellar surgery, I just want to ask, what are your thoughts about shared tissue, where tissue can be used for, say, 2 patients for DOLC, and for DMEC is the obvious example there itself. I know in the US now, obviously with pre-stripped tissue, you then have that stroma available. Just some thoughts on that.
I think it's a useful idea. I think it all comes down to, well, I don't think there are any ethical issues really. I think it's more the procedural and safety issues, because you're giving tissue to 2 different patients. So where that tissue contaminated, you've doubled the risk, but we know that generally speaking, the risk of contamination is low, and the risk of transferring something like CGD is very low. I think it's the way to go, since we just don't have enough tissue. In Australia and New Zealand, particularly in New Zealand, we struggle to get enough tissue every year.
Great. So our next speaker is maintaining on the theme, talking about a specific form of lamellar surgery. So it's a great pleasure to invite Rajesh Fogle. He's going to be talking about DLK. Thank you, Rajesh.
Thank you, George. Good morning, everyone. After hearing Charles McGee give a good overview of all the lamellar techniques and the various, advantages, disadvantages, I'll come to talk about DALK, which stands for deep anterior lamellar keratoplasty. No financial interest to disclose. Now, deep anterior lamellar keratoplasty refers to a surgical technique where 80 to 90% of the host stroma is replaced with healthy donor tissue. And the advantages are basically it preserves the host endothelium, thereby eliminating the risk of endothelial rejection. It's a closed globe surgery compared to penetrating keratoplasty, and you can do much larger size graft without the risk of rejection. And acquiring a tissue from the eye bank is easier because you're not dependent on very good cell counts. The indications, yes, primarily, most commonly we do it for ectatic disorders, but you can also do it for scars, various dystrophies, degenerations, sometimes combined with ocular surface reconstructions, and rarely for recalcitrant infections which are not responding to medical therapy. Primarily, there are two main techniques that have been described. One that involves injection of air, fluid, or viscoelastic into the stroma to create a plane of separation between the stroma and the predecimus layer, and the other is the manual layer-by-layer dissection, where you try to reach as close to the decimus membrane as possible. Now, the big bubble technique, which is one of the more common ones that we do, was introduced by Mohammed Anwar, and here a 27-gauge needle is used to inject air at a deep stromal plane. And we used to think the surgical steps are basically a deep trephination, debulking, air injection, deflation, excision of the residual stroma, and then put in your graft. We always used to initially think that the plane of separation is between the stroma and the decimus membrane for a long time, till Harminder Dua showed us the presence of a layer called the predecimus layer, or the Dua's layer, and which gave us a better understanding of what happens when you inject air and you create the different types of bubble. What we refer, the classical one is the type 1 bubble, which is a separation between the stroma and the predecimus layer. A type 2 is a separation between the predecimus layer and the decimus. And the type 3 is where it starts as a type 1 and then breaks on to become a type 2 bubble. So you get a mixed bubble. Now, the objective is that how can we consistently achieve a type 1 bubble? Well, I think a pre-op evaluation is very important. Do the slit lamp biomicroscopy to see the extent of pathology and see how deep the cornea is involved, whether it involves the posterior layer or not. And I think an anterior segment OCT is very helpful in that, because you can see if the scarring process involves the predecimus layer or the decimus. And if it does, then you avoid injecting air, because if the posterior layer is abnormal, then you're going to have an abnormal response to the air injection. So some of the conditions where you should not be doing a big bubble are macular dystrophy, maybe very advanced keratoconus with extreme thinning, and if you have pre-existing scars that involve the decimus membrane. Instead of a needle, use a cannula, which is blunt tip, as a bottom port. The advantage is in the learning curve, less chance of complication than working with a very sharp needle at a deeper plane. How do you reach the ideal plane? Well, when you do surgery and you are advancing the cannula, you feel an ease of resistance that tells you that your cannula is in the right plane. But there are other means as well. You can use a diamond knife to create a initial cut at 90-95% depth and follow that plane for the introduction of cannula. You can keep the pupil dilated, and against the retroillumination, you can look at the cannula and the wrinkles that develop in front of the cannula, and that tells you that you are deep enough. Or if you have intraop OCT, you can create the track first and then look at how deep the track is. And if you want, you can come back and revise that before you inject the air. Newer femtosecond laser with have integrated OCT like the Zuma Z8, you can see in cross-section the track that is created by the femtosecond laser, and that track can be manipulated to make it very close to the decimus, and that allows you to have greater success in achieving the peak bubble. There is an inverse relationship between the intraocular pressure and the diameter of the bubble, because as you are injecting air and creating the bubble, the aqueous does not have any place to displace. So as the bubble forms, the intraocular pressure rises, and sometimes that can exceed the bursting pressure, and you can have a spontaneous burst. So what we do now is we do a sequential injection where we initially inject air to create the bubble, and once the bubble is initiated, we do a paracentesis, release the aqueous so the counter pressure is minimized, and then when you expand the bubble, you find that the chance of a spontaneous rupture of the bubble is minimized, and you can expand the bubble to much larger diameter than what you would do without releasing the aqueous. You can use cohesive viscoelastic instead of air to try and create a visco bubble. Works the same way, but you need a softer eye because the viscoelastic is more dense compared to air. That's the kind of typical post-op appearance that you see, a nice clear graft, healthy cell counts. On the anterior segment OCT, you can see that the cornea is restored. Femtosecond laser, the advantage is you can make shaped incision, either mushroom, top hat, zigzag. You have a larger graft-host junction surface area. You can customize the shape beyond what the Trefine can do, and the integrated OCT does make it much more helpful during the procedure. So here you can see that we have done the initial cut with the femtosecond laser. We can remove the anterior cap. So we do an anterior 200-250 micron lamellar plane. which is dissected, and after which the track, you find out the track that's already been created by the femtosecond laser, introduce a cannula into that, and then when you go ahead and inject air, you can see that because the track is very close to the decimates, you can create the big bubble very easily, and thereby you can shorten your learning curve when you do the surgery. That's how it looks post-op, and if you see, it basically induces less amount of astigmatism because of better apposition of the graft source junction. And this is while the sutures are in, although when you remove the sutures, sometimes you can get unpredictable astigmatism as well. In the learning curve, this comparative study from Moorfields, where they looked at femtolaser versus manual DALK, they found that the rate of intraoperative decimates perforation and the rate of conversion to a penetrating keratoplasty was much lower when you were doing a femtosecond laser assisted DALK in a multi-surgeon setting. Common complications, yes, you can have a double anterior chamber, especially if you have encounter a perforation during the surgery, but this can be managed by rebubbling or putting an air bubble in the anterior chamber. But when you do that exercise, you have to be careful about not inducing a pupillary block or a Ureth-Zavalia syndrome. So what I like to do is intraop, if I do have a perforation, I like to do a inferior surgical iridectomy at 6 o'clock position, thereby learning from our DMEC and DSEC procedures that you can leave behind a complete airfill without the risk of perforation. If you get a type 2 bubble, this comparative study looked at whether you try to expose the type 2 bubble or you go ahead and do just release the air, or you just do a near manual dissection till the decimates. And they found that if you try to attempt to bear it, you will more likely end up with a penetrating keratoplasty because the decimates is very fragile. You end up with a macro rupture. So the learning is that if you have a type 2 bubble, and just you can do a manual dissection near decimates and complete the surgery rather than attempting to open it up. Outcomes of DALK has been variable. In single surgeon settings where they are more experienced, you find that the visual acuity results are much better, but in a multi-surgeon setting where different surgeons have different experience, sometimes if the surgery is not done properly, you leave behind a irregular interface, you can have suboptimal results compared to penetrating keratoplasty. But this nice study from Moorfields, again, where they had surgeons, multi-surgeon setting from beginner to expert, they found that almost 77% of the patient had a corrected distance visual acuity of or 20/40 or better and less complication rate. For scars, if they are involving the decimates, you can do this manual technique, which is basically a variation of Malbrun's peeling technique, which has been described long back. So we do a deep trephination, we debulk the cornea, and then we come back to the periphery, and at the depth of the cut, we make a peripheral pocket. I prefer to make this pocket going along the trephination margin, and then you can use a tooth forceps to grasp the residual stroma, and as you try to peel it, you will find that you see the separation spontaneously occurring, and you can assist that with a lamellar dissector just to break the fibers. So this helps maintain a uniform plane, and you can get a very nice interface. So you can see that post-operatively, in a case of high drops, you can do a manual DALK, and on the OCT, you see a very nice uniform bed. And at times, the residual bed is less than about 80 to 100 microns, and the results can be quite comparable to big bubble DALK. Just the rate of recovery is a little slow. So if you look at 6 months or 1 year outcomes, the outcomes are comparable between the two groups. Intraop OCT is a great tool, expensive, but if you do have it, it allows you to see the amount of residual bed that's remaining, or if you have a complication, it's easier to manage. This flowchart gives you an overview about how to manage the DALK surgery. I don't see a timer, I don't know. I've not heard the beep till now, so I think I still have time.
You're okay.
Yeah, post-op medications, we do use steroids, but you can taper them quite quickly because the risk of endothelial rejection is not there. But I like to use softer steroids till the sutures are in, because if you stop them, you find that your sutures can develop some infiltrates or vascularization, or they can become loose. Depending on the, because a lot of keratoconus patients also have history of prior allergic eye disease, so steroids need to be continued to prevent that from affecting the outcome. We can use non-viable tissue like this gamma irradiated corneal lenticules, which are available from the eye bank vision graph. We did use it for 6 eyes, and we did DALK, and we found the outcomes are quite similar, just that the clarity of the graft is not as good as a fresh tissue, and the epithelialization takes longer. This is a nice study from Vito Romano and Massimo Busin, where they use dehydrated lenticules. So they took donor corneas that were not used in a sterile chamber, they dehydrated them, and they stored them, and whenever required, they put it back in the organ culture for a day. took samples for microbiology, and if they were negative, these corneas were taken and they used it for DALK, and they found that compared to fresh donor and these, the outcomes were not different, both in terms of clarity or the visual outcomes. Cases like this, where you have extensive thinning like a pellucid, you can do large diameter DALK, and you do some amount of manual dissection, maybe a central big bubble, and you can see that even with this patient was operated in 2008, and after 17 years of follow-up, 2025, still maintains a nice clear graft. The contour is maintained and minimal astigmatism. These kind of ectatic graft junction of penetrating grafts done earlier where the graft is still clear, and you can go ahead, do a large diameter DALK as well in these kind of scenarios, and you see that's the kind of outcome that you have. You have Tyrrhen's marginal degeneration. Sometimes we do crescentic or banana grafts, but when the involvement is very large, you can go back and similarly do a large diameter DALK. Here, what you have to do is when you're doing the conjunctival peritomy, you advance the dissection a little bit into the cornea to harvest the limbal stem cells, the palisades, so that you don't, initiate a limbal stem cell deficiency by doing these large diameter DALK. Keratoglobus like this, when you have massive, you can do, again, large diameter DALK. In the interest of time, I'll skip the surgical steps, but you can see that you can restore the cornea back to normal. And this patient has finished almost 8 years of follow-up and still maintaining pretty good vision. The other technique of doing it is again in a keratoglobus with blue sclera, where the peripheral sclera is also thin. You can do a procedure called as a tuck-in lamellar keratoplasty, where you do a large diameter, like a 10 millimeter trephination, then with a diamond knife, we make a groove. We do a little bit of back dissection. So you prepare the donor tissue, which has a peripheral 1 millimeter flange, and the flange is then tucked into this pocket that you create. So you can see that that's the dissection that's been done. That's the back pocket that we are creating. And when you prepare your donor tissue, you prepare it on an artificial chamber using a similar technique of making the groove, doing the back dissection, removing the anterior part. And when you punch it out, you see that that's a donor tissue with 1 millimeter flange on the external side. And then this is then tucked into the pocket. And you can see that's how the eye looks post-surgery. The advantage is if your periphery is thin, you don't have a problem in suturing your graft. And also, in using this technique, you don't cross the limbus, so you can preserve the peripheral limbal stem cells as well. You can combine it with unilateral chemical injuries. We do a DALK with conjunctival limbal autografts, and that is quite useful as a single-stage surgery to reconstruct the surface. That's the same patient, 17 years follow-up, following a lamellar graft with conjunctival limbal autograft. You can see that the surface is still very well maintained. Recalcitrant infection, like acanthamoeba keratitis, not responding to medical therapy. When the infection is in the anterior half and in the central cornea, you can go ahead, do a DALK, and still achieve a successful outcome. There have been reports of performing similar surgeries in fungal keratitis or in bacterial keratitis as well. Perforation, this is a patient post-corneal ulcer, had a perforation. They had a glue and an amniotic membrane. This was referred for a penetrating keratoplasty. We went ahead, did a manual deep anterior lamellar keratoplasty, and you can see the patient had 20/30 vision with good cell count. So you don't really need to sacrifice the cornea and do a PKP in these kind of scenarios. So basically, in conclusion, I think DALK should be considered the procedure of choice for corneal disease whenever you have the endothelium that's healthy. Surgical techniques continue to evolve, ensuring greater success of big bubble. So I think don't go and do big bubble for every case, but if you select your cases properly, you will have a greater success of getting the big bubble. In future, the femtosecond laser with the integrated OCT definitely will help make the surgery easier and improve outcomes in future. Thank you. Thank you for your patient hearing.
Great, thanks, Rajesh. Any questions from the floor for Rajesh? So, can you use the microphone? Can you use the microphone? Use the microphone.
In case of perforated corneal ulcers, which have healed actually, so any difference in dissecting the lamella you do when the perforation?
The thing is, whenever you deal with a perforation, either intra-op or in these kind of scenarios where there is a pre-existing break, the key factors are doing a deep trephination, so you know where you are starting off. And you can always start in the normal, so opposite to the quadrant where you have the perforation, and you can do the surgery from there. Keeping an air bubble in the AC also prevents the air from leaking out. And instead of using a semi-sharp dissection, at times we also have to use a little bit of sharp dissection to prevent too much of, because every time you manipulate, the air doesn't stay in the AC, it keeps coming out.
And do you do a PI in this case also?
Yes, because we leave a complete air fill, so we do an inferior PI. And sometimes instead of air, you can use non-expansile mixture of SF6 to retain the tamponade for a longer period of time.
Thank you, sir.
Rajesh, just one quick question.
Yes.
Just, I mean, Charles alluded to this as well, where he showed trends in the transplantation rates and showed an increase in regrafting. And one of the issues that, you know, people will say this to me all the time is the fact that the problem is the number of lamellar transplants globally has gone down. You know, which is great, thanks to cross-linking, because keratoconus was the leading indication. And the problem is that, of course, from younger people in the audience who are trying to learn then, this is a bit of an issue because you have a massive range of experience and you showed a whole array of cases over here itself. But some of these cases with people starting off, it's impossible for them to take on perforated cases or high drops and things like this. And because the number of keratoconus cases, which we generally think are quite easy to do for a lamellar surgeon to start, are not there anymore. You know, some even big centers, I mean, Bruce is here as well in the meeting. Bruce told me last year, I think he only did 12 or 10 docs in Moorfields and stuff. So what would be your advice then for younger people, and how are they going to get the experience when the numbers are down, which is probably a good thing?
Well,
or should we rationalize the care and limit it to certain centers, so maybe these cases should be sent to certain centers where people have a higher volume to reduce those complication rates? Which just some thoughts.
I completely agree with you, because the learning curve, unless you do a significant number of procedures, it's very difficult to, you know, overcome the learning curve. So one way of doing it is referring to a center that does more volume of talc, so that the patient gets a better surgery and a better visual outcome. Maybe future technology like we have with the Zima Z8 that we use, if it does some of the steps that can ensure uniformity, that even somebody early in the learning curve can achieve a similar result, that is where I think we will need to look at that. In terms of indications, the US data is always misrepresented because there the insurance doesn't pay out. So when we talk to the surgeons, they feel that the amount of effort that they put in for surgery, they are not getting the remunerations. A lot of people are not doing it because the surgical specialty charges them more for per procedure. So they actually, the patient has to pay more if he has a DALC compared to a penetrating keratoplasty.
Okay, good. All right, thanks for this. Thank you.
Okay, the next speaker is Associate Professor Ji Jiang, who comes from New Zealand and the New Zealand National Eye Centre. Ji is a lab scientist, but also is involved in our teaching lab and our microsurgical lab. And our particular interest is endothelial survival and progression.
Thank
you,
you,
Ji.
Charles. Today I'm going to talk about strategies to replace or repair the endothelium, and then touch on some strategies that prevent endothelial damage from happening in the first place during cataract surgery. So we know that corneal endothelial damage can come from endothelial dystrophy, such as Fuchs endothelial corneal dystrophy. But it can also stem from cataract surgery, resulting in pseudophakic bullous keratopathy. So in this talk, I'll talk about DSO, also known as DWIC, ROCK inhibitors, other non-surgical treatments, EndoArt. And then for replacement, we're going to talk about human corneal endothelial cell therapy, magnetic endothelial cells, and then we'll talk about the endoprotecting practices for cataract surgery. So starting with DSO, also known as DWIC, the procedure is very self-explanatory in its name. So it involves removing a central piece of Descemet's membrane without replacing anything, without replacing with an endothelial graft. So now there have been over 200 cases completed with an overall success rate of 85 to 90%. So this procedure involves no graft, so there's no rejection and no corticosteroids. And it's relatively easy to perform, so there's no sharp learning curve. And if it fails, it can be rescued by DMEC. But the disadvantages are that it's limited to early Fuchs dystrophy with a healthy peripheral endothelium. So you need that peripheral endothelial reserve for it to work. And the corneal clearing can be quite slow, taking an average of 3 months, but keep in mind that the range can be between 1 to over 12 months, which can be quite devastating for the patient. So how do we speed up this clearing? That's where ROCK inhibitors come in. So Repasido is the first ROCK inhibitor to be approved for the treatment of glaucoma in Japan. On top of effects shown in the trabecular meshwork, it also promotes the proliferation, migration, and adhesion of corneal endothelial cells. And it also inhibits their apoptosis. So in a trial by Dr. Maloney et al. In Australia, they treated 23 Fuchs patients after 4 millimeter DSO with Repasido 6 times daily until clearance. And the outcomes were very promising, showing almost all the eyes cleared at an average of 4.1 weeks, so which is much better than the 3 months. Best corrected visual acuity improvement averaged 0.156 logMAR at, I think it's at 3 months. And then 39% of them relapsed, but all managed to clear after restarting treatment at a lower dose and only for 2 weeks. So the company that makes the drug did a dose response trial comparing 4 times to 2 times daily Repastidil. And then they found that the 4 times daily which was much better than the 2 times, in resulting in a much higher increase in central corneal endothelial cell density at 12 weeks and a much larger decrease in central corneal thickness at 52 weeks. So it took these eyes an average of 35 days, which is 5 weeks to clear with 4 times daily treatment, which is slightly longer than the 4.1 weeks that you get with the 6 times treatment, 6 times daily treatment in the last trial. So now there are a lot of ongoing trials for Repastidil as a post-op treatment after DSO, cataract surgery, and DMEC. But there's no trial for Repastidil as a standalone treatment for the treatment of corneal endothelial diseases. So that's where Nitasidil comes in. So Nitasidil is a second ROCK inhibitor that's approved for the treatment of glaucoma, but this time in the US. So now in this trial, they treated 29 Fuchs eyes with Nitasidil once daily for 3 months and compared it to placebo. Outcomes show a 24 micron corneal thinning average at 3 months from a baseline of 590, and best corrected visual improvement of 1.99. So there are some moderate effects on its own. So the company that produces Nitasidil did a dose response trial comparing once and twice daily. And they found that once daily was actually better than the twice daily. So as you can see on the graphs on the right, the solid lines represent the once daily, the dotted lines, the twice daily. You can see an improvement in central corneal thickness of 36 microns by 2 weeks. And then an improvement in best corrected visual acuity of 5 letters by 2 weeks. But as you can see, the effects start to wear off, and they start to gradually return to the baseline. So it appears that Nitasidil is probably not sufficient on its own for treatment of Fuchs dystrophy, based on the evidence so far. But what about its combination with DSO? So in this trial, they treated 10 eyes with Fuchs dystrophy and with DSO with once daily Nitasidil until corneal clearance. And the result is an average of 4.6 weeks to clearance, which is very similar to the results that you achieve with Repastidil plus DSO. But keep in mind that this is only once daily versus the 4 to 6 times daily required for Repastidil. In the fellow eyes, they deliberately delayed the treatment until 2 weeks after the clearance time of the first fellow eye. And they were able to demonstrate rescue within 1 to 2 weeks of starting Nitasidil. But these eyes did end up having lower endothelial cell density at 6 months, and a different morphology, as you can see on the graphs on the right-hand side. And then in this paper, they noted that all the treated actually had a honeycomb corneal epithelial edema, which was later confirmed in the literature as a side effect of Nitasidil. So that's probably why that the twice daily is not as good as the once daily, and then why the effect on corneal thinning wears off. So there are other repair strategies being developed for corneal endothelium. There are 3 that target oxidative stress, including NAC and the sirolimus eye drop. The trials are both recruiting, and then there's a trial on an peptide, which show no difference in central corneal thickness. There's an FGF analog, which has completed an efficacy trial with the results published but not revealed yet. There's a gene therapy to treat the TCO4 trinucleotide repeats in Fuchs dystrophy, but unfortunately the trial was aborted due to the lack of participants. So we now have EndoArt, which is an acellular physical barrier that stops fluid entry from the endothelial side. So it's like a waterproof bandage, kind of. So it requires a dexamethorexis, an iridotomy, gas tamponade, and an anchoring suture to keep it in place. In a recent review of 24 cases, central corneal thickness reduction was seen from a baseline of 771 average to an average of 580. The follow-up time ranged between 1 to 17 months, because these are all individual cases or case series. Best corrected visual improvement was demonstrated in 70% of the cases, but it came with a quite high rebubbling rate, and also came with cystoid macular edema and raised IOP. So the conclusion for this case, this review is that this is really reserved for complex eyes with a high chance of keratoplasty failure if you stick another graft in. 2 clinical trials have been completed, but the results are not published yet, so we really want to see those results. So moving on to replacement of the corneal endothelium, we have human corneal endothelial cell therapy led by Professor Kinoshida's group in Japan, showing very promising results. They treated 11 bullous keratopathy patients, followed by endothelial and decimated membrane scrape, followed by the injection of the cells and ROT inhibitor. And the patients are required to face down for 3 hours to face down for 3 hours to facilitate attachment. The outcome showed that they achieved complete endothelial coverage in 10 out of 11 patients from 6 months, and the endothelial cell coverage at 5 years is still over 1,200 cells. A reduction in central corneal thickness was seen from 4 weeks, as you can see from the middle and the bottom graph, and also there's an improvement in best corrected visual acuity from 4 weeks onwards. And they both continue to improve and maintained until 5 years. So this was approved in Japan for the treatment of bullous keratopathy, and the company that's our license to is now conducting 2 dose response trials and 1 on the use of cryopreserved corneal endothelial cells. And then another company, MSL, is taking it 1 step further by incorporating magnetic nanoparticles into the cells so that the patients only have to wear a magnetic eye patch for 3 hours. Most strikingly, this trial was done without endothelial brushing or DSO, which means that they did not remove any endothelial cells or descemet's membrane before injection of the cells. So they injected 3 doses of cells, low, medium, and high dose. And the outcomes are available from a company press release only, which is not peer-reviewed, in 3 sentences, basically. So they say that the cohort receiving the low dose of cells achieved the 11-letter mean change in best corrected visual acuity at 6 months. All the cohorts tested show improvements in BCVA and CCT, but we don't know for how much and at what time point, and then how the different doses compare. But they did know that there's no serious adverse events. There are 3 other trials registered under this company. One involves repeat injections of the cells plus Repasdu. The second one involves injection of the cells either at the time of cataract surgery or afterwards. The third one compares cells with or without endothelial brushing and DSO. Shall we skip this? No, okay. Okay. So let's just touch on protection from cataract surgery. There's plenty of evidence supporting the use of dispersive viscoelastic and the soft shell technique to protect the endothelium. So it results in at least a 50% reduction in endothelial cell loss at 3 months. And then there's evidence supporting the use of torsional ultrasound, the nanolaser, and femtosecond laser-assisted cataract surgery to protect the endothelium. They all show significant reductions in endothelial cell loss versus conventional ultrasound. And then for those high-risk eyes, such as those with prior PK, extracapsular cataract surgery resulted in significantly less endothelial cell loss versus phaco, but this it produces no difference for routine eyes. So in summary, to protect the endothelium, we can consider these practices for high-risk patients undergoing cataract surgery. For repair of those eyes, which cannot be protected like those with dystrophies, we can have DSO plus Repasdu or Nitazoxanide to speed it up. Nitazoxanide on its own demonstrated moderate effect, which is limited by epithelial edema. There are a range of other treatments being developed, and then we have EndoArt, which is reserved for complex eyes. And then for replacement, we have PK, DSEC, and DMEC. And then human corneal endothelial cell therapy is looking promising. Magnetic endothelial cells are just pending peer review results. But the prospect of doing cell therapy without endothelial or dense matrix membrane removal is quite exciting because it then becomes a non-surgical treatment that doesn't require the operating theater. That's all from me today. Thank you so much.
Thanks, Ruth. That's a very clinical talk for a lab scientist. You did a fantastic job, I tell you. I think Charles gave you a hard task there. Any questions from the floor for G? mean, I think this is a very exciting area for people, younger people in the audience who want to go into an area for research and clinical, because this has changed dramatically over the last sort of 15 years, and I think you can see the exciting technology. I mean, to answer the question, so just as a scientist hat on, just to make it a little bit more interesting, you talked about the technology from Emisil, from the magnetic beads on very nanoparticles on the endothelial cells, and Ellen, who's one of the advisors on this, who came out of Bascom Palmer, it's, as a biologist, what do you think about the concept of injecting endothelial cells on a layer of endothelial cells, probably with Gutte there as well, and injecting cells on top of cells with respect to a functional aspects of the endothelium? Because logically, well, I mean, I don't want to give a Q&A thing what you think, but just to mention, what do you think about that concept of actually not removing Gutte or endothelial cells and injecting cells on cells?
As a scientist, I don't think it's going to work.
Yeah.
Because you need a molar
go on.
layer.
Yeah.
You can't have cells, growing on top of each other for the
Yeah.
molar layer to work. You need
Yeah.
a molar layer for the barrier and pump function. But I don't know how they get the results.
Yeah, correct. So I mean, I completely agree. I mean, people ask me all the time and stuff like that. I'm not quite so biased. So it's interesting that even with Chiguru's data, when you look at Gutte, obviously Fuchs is the leading indication for endothelial disease. And if you look at from the time of cell injection to the time of within the first 6 months post-operatively, the Gutte will come back, right? And then and it's because the cells that are lying on top of the Gutte there itself die because there's no basically nutrition from that cell itself.
Yeah.
And the driver, I mean, I can tell you, I know Jeff, who's the CEO of that company, Jeff's driver for that itself is to make it an office procedure.
Yes. Yeah.
So you don't need to then take the patient to OT, and you can just whack the cells in and then basically get them. But I just wanted to see what you thought as well. But I mean, I agree. I think the same as well.
Yeah, in theory it doesn't work, but they didn't say how they select the patients. So I don't know whether they select the patients without any endothelium left or
But it's a bit of an issue.
if there's no endothelium left, maybe it could work.
I mean, just you mentioned also about basic FGF as well. I can tell you I was on the advisory board for that as well.
Yeah.
And so it's interesting, basic FGF does work. And the results are actually, again, like you said, it's not published, but this is just from the company data. But I can tell you it worked. In the phase 2 study that was done, there were 3 groups. One was basically using it topically post-operatively, and one was doing what they call basically stop and done, which is at the time of doing the DSO, you inject the FGF. And actually, amazingly, it worked better than the other 2 groups.
Yeah.
Unfortunately, the financial backing of the company has basically gone away from that, and now they're looking at using it as a protector for endothelial for cases with patients who are having cataract surgery as an So it's moving from your group that you showed from regeneration to protection, because obviously that's a larger market. And FGF it's interesting. It's basically working as a process to prevent ferroptosis, which has now been shown as a key driver for endothelial cell death, especially in foods.
Especially for cataract
So
surgery.
you can move it. Hopefully, you'll be able to move it to your protection column with some hopefully data coming out. But again, they're now looking at reinventing that. But it's safe. I mean, it's a safe thing to have done. I saw the data from the thing there. And it's pretty good. But unfortunately, it's not going to be used in the DSO group anymore.
Okay.
Okay. Thank you. Thanks.
Thank you, George.
I think Dr. Chen is not here. So we'll have next Dr. Natalie Allen. She's a medical doctor and PhD at the University of Auckland, Department of Ophthalmology. So we'll be discussing, I think her interests are eye donation, corneal transplantation, and special interest in cornea in COVID-19 and graft rejection.
Hello, thank you so much for having me. I'm really excited today to talk about my PhD to people who actually want to hear about it, which is great. Thank you to my supervisors. Just no financial disclosures. So I know COVID was very traumatizing for everybody, so I promise I'll make this as pain-free as possible, but there is a lot to talk about, so I'm going to go through eye donation, the indications, the clinic attendance and delays, then a bit of clinical outcomes, and then a little bit about graft rejection. So global eye donation, so this is something that India does exceptionally well. So 35% of countries are self-sufficient, which means they don't need to import any corneas at all. 40%, which is New Zealand, use a combination of ones that they source locally and import, and 27% of countries use only imported corneas. However, the countries that are so good at getting their own corneas do the most transplants, which includes India and the US. So 89% of all transplants performed are actually sourced locally. And India has the most eye banks in the whole world, which I thought was awesome. So, obviously during the pandemic, there was a significant drop in corneal donation just due to logistics and people's anxiety around donation processes. So there was a significant decline in elective procedures, but emergency keratoplasties remained, so there was still a demand, and there was therefore an increase in global trade of corneas. So this is some New Zealand data just showing here 2020, obviously, pandemic horror. That blue line is our importation from Australia as our own donation rates dropped. So eye banking, obviously, this was really tricky. Some studies found that COVID can actually live for 7 days post-mortem, which is horrifying. So we have to be really careful about not transmitting COVID via a cornea. However, the universal and selective testing remains controversial because it's really expensive. It takes 3 days, and that's prime cornea harvesting time. And there's never actually been any recorded incidents of COVID being transmitted by a cornea, but it has occurred in solid organs. So in terms of the indications, there was a significant drop. This is the New Zealand Auckland data showing the decrease in numbers that were formed in 2020 and a slow, steady increase since then. So the number of urgent grafts remained unchanged, obviously, because those were emergencies, but these were a high rate during the pandemic, and there was no obvious change in the clinical outcomes of grafting during this period. This is just a brief look at our indications. So as our Prof alluded to, our main indication now is regraft, seconded by keratoconus. And basically the ratios stayed the same. We were just doing slightly less of everything with a slightly higher ratio of urgent keratitis and trauma. In terms of our clinic attendance and delays, New Zealand was hit pretty hard with lockdowns. So we had very strict policies about who could come to clinic and who couldn't. So there were quite substantial delays, but international data showed it was pretty similar. So the average delay for a corneal graft was about 6 months during the COVID-19 pandemic, and corneal cross-linking was delayed by about 3 months. And then all of the corneal graft follow-ups were delayed by about a year, and this is in keeping with our New Zealand data as well. Some overseas data has shown that this did result in some worse clinical outcomes for vision in the post-operative period, and keratoconic patients were more likely to progress as they waited for their cross-linking, which makes sense. This is just a lovely graph of our sort of did not attend appointments, or the appointments that were offered versus the ones that people actually attended. So there was significant hesitancy, obviously, about coming into a healthcare environment during COVID. So there was a gap in those attendances during that time. However, in New Zealand, we did quite well with our delayed clinic appointments, and there wasn't a significant increase in appointment delays, and this has since continued to improve post the pandemic. So in terms of clinical outcomes, obviously visual outcomes vary a lot, as we've heard already, about the type of graft and also the patient that the graft is performed on. But so far, we found no statistical difference in the initial visual outcomes during the COVID-19 years, which is good news. We did find on linear regression that a higher number of delayed clinic appointments corresponded to a worse visual acuity in that initial year post-graft, which again makes sense, less follow-up. And then a little bit about graft rejection. So we published this paper looking about the correlation between a COVID-19 vaccination and corneal graft rejection. So we did a big literature search, and we included 38 studies in this paper. The estimated incidence from the accumulation of all of those papers was about 0.004 per million, and there was no difference in the type of vaccine that was used or the graft. And the majority of cases were treated with topical steroids. About 25%, the rejection was a bit serious and required systemic steroids. However, the evidence is generally quite poor. So the vast majority of these were case reports and case series, and the numbers weren't really big enough for statistical significance. There were 2 large retrospective studies that found no increase in graft rejection during the vaccination period at all, but the overall perception is there may be a small link. And then for COVID infection itself, so basically if you Google Scholar or PubMed COVID-19 infection and anything, you do find some results, I will say. There was so much literature. but the literature is even more sparse for COVID infection itself. So there were just a few case reports, and these did not reach statistical significance. So in our study, we looked at all of the graphs performed from 2018 to 2022 with a mixture of online and paper results, looking at all the demographics, the indications, the appointments, and the outcomes, just in our Auckland-based centre in New Zealand. And we found that rejection was not associated with ethnicity or gender, and it was associated with younger age, which is well known in the literature. However, there was nil statistical increase in rejection during the period at all, and the number of delayed in-clinic appointments in the first year post-graft increased the likelihood of graft rejection. But there was no association whatsoever with concurrent COVID-19 infection or vaccination and corneal graft rejection so far in our data. So therefore, in conclusion, there was decreased donors during the pandemic, as to be expected. The graft indications remained primarily unchanged, but more acute grafts occurred, obviously because there were no elective procedures happening. It was increased number of delayed appointments, with worse initial visual outcomes associated with increased risk of graft rejection, and there may be some link between the COVID-19 vaccination and graft rejection, but this needs a little bit more literature. So what we're looking at going forward is we're currently doing the statistics on a much larger analysis of all the graft incidences from the last 22 years, so 12 years from 2010 to 2022, aiming to identify any of the risk factors and assess the ongoing outcomes prospectively of those grafts that were performed during the pandemic and see if we can find some slightly more substantial literature. Thank you so much for your attention.
Great, thanks, Natalie. Any questions for Natalie, Dr. Allen, on this topic? Okay, Natalie, I'll just ask a quick question. The association with vaccines and rejection is well documented in the literature, right, for corneal transplantation itself, and of course, but obviously with COVID, there was a mass vaccination like never been seen basically before itself. To be fair, New Zealand handled COVID very well, right? So so maybe if you repeated or look at the data, say from another country, I'm just picking one, not being biased, but say Brazil, for example, where access to care wouldn't have been so good.
Yeah.
And generally, to be fair, most of us would say Brazil didn't really handle COVID that well. Do you think that the conclusions that you drew would be different in different settings? Yeah,
definitely. So our centre, if I say so myself, is quite good, right? So we have our patients have really good return advice. They know to come if they have any issues. We did keep our access quite good, and we have really good sort of management and bookings and things like that. So I think in a centre where there was less strong infrastructure, I think, I would agree, the outcomes probably wouldn't have been so nice.
So, the last comment you made was about the lack of evidence, obviously, with the thing itself. So, if you see a patient, a lot of people undergo influenza vaccinations now, right? So, in Singapore, it's very popular. What's the advice then for them having, with respect to their steroid regime? A lot of the EKs are still using steroid once a day. Maybe the PKs also basically using their steroids once a day. If they're undergoing vaccination, what kind of advice do you give the patients?
So we usually increase that up to about QID, just in a few days before, a few days after, and then just give them really, really good return advice. Happy to see them and admit them if they have any rejection. Yeah.
One of the things you noted was that there was an association between delayed appointments and rejection. Mm-hmm. Do you think that the results were poor because of that? Did people have more severe rejections, or because I know obviously I'm from New Zealand that we actually had access for emergencies? Do you think it's an educational thing that if you're coming regularly, people are reminding you all the time you might get a rejection, and therefore you're going to come back at the first symptom? Why do you think there's that association?
Yeah, that's an interesting question. I think that some patients are just incredibly onto it. And so they'll come in if their vision drops by 2 lines, and other patients, it's really worth seeing them regularly because they may not. In New Zealand, we have quite a variable, diverse population and variable levels of health literacy and awareness about their grafts. And so some patients, I do think, would definitely benefit from regular follow-up more than others. Yeah.
I think from India, the results were very different.
Okay.
I don't want this room to feel that we have enough tissue. In India, we do about 25 to 30,000 transplants, while we need about 100,000. So we have a lot of eye banks, but only about a dozen do it well.
Oh, interesting.
So it's not uniform. Number two, I think because a lot of our transplants are for acute infections,
Yeah.
so we reserved all our tissue for those
them.
acute perforations and things. So our indications actually changed. A lot of elective surgeries, were abandoned,
Yeah.
and it was only for acute infections,
Interesting. Okay.
perforations and melts.
Yeah,
And
melts,
things. So
yeah.
here the situation was different, and we did lose a lot of transplants because of delayed presentation. There were a lot of infections and rejections, and no, those who had transplants, they came in late.
Presented late. Yeah.
And we also, again, anecdotal, but the vaccination and
Yeah.
rejections, they were cases
Yeah.
that presented that way.
Yeah.
One intervention we thought made a difference was for patients not able to access was we instructed the patient's family members to take photographs of the eye using
Oh,
their
nice.
smartphones, and that could help the treating surgeon, like the corneal surgeon, look at that and say whether that's a broken suture or that's a loose suture or whether that's something like looks like a rejection. So by the time the patient, even if they have a delayed appointment or they're not able to make it, at least the initial treatment can be started, so thereby you can avoid losing the corneal.
Yeah.
And I think the other thing about what we noted during this period is because of lack of available donor tissues, people were using glycerin preserved tissues which were non-viable, but they were using it just to seal the perforation. They were using sclera for closing perforation. So it gives us insight that in future, maybe eye banks, to try and reduce the wastage, we can look at non-viable long-term storage of donor tissue which can be used for emergency purposes.
Yeah. Interesting.
So we have the similar thing, but we have a transplant nurse who's
Oh,
on
great,
call
yep.
24/7 with a phone that the nurses
Oh,
will share. So there's
that's
3 of
nice.
them that will share a phone. So exactly that point. Most modern smartphones, their actual macro is so good
Yeah.
that you can take a picture of the anterior segment. At least you know if the eye's red and things like that as well, or whether they need to come. So they will take a photograph, send it to the transplant nurse, so that the patients have that number. So it's a universal number that
Wow.
they send in, and then they will send it to the equivalent doctor then to say, yeah, okay,
Right,
maybe
okay.
we should see, maybe we shouldn't see
24/7.
itself. Yeah, so they basically will send ideally you don't call them at night time, but anyway, but it was a way of trying to help with the cancer. So we run that on, and that's been something that we've kept on afterwards now as
Great.
well. But similar, your access to care is pretty good. It's similar to ours, but it's just a way of sort of saving them a trip down to the hospital,
Yeah,
basically.
definitely.
That's great.
Cool.
Great, thank you.
Thank you.
Thank you.
So our last speaker is Dr. Stuti Mishra. She's Associate Professor and Optometrist Scientist at the University of Auckland. Interest in anterior segment imaging, ocular surface disease, and corneal interventions. Over to you. Thank you.
Thank you for the introduction. Okay. I have no financial interest to disclose, although you might think so by the end of this talk that I do. So in the next 10 minutes or so, I'll talk about in vivo confocal microscopy of cornea, whether it can be used as a diagnostic tool or only a research tool. We'll discuss about corneal diseases and also corneal surgeries, and whether this tool can be used, or these images can be used to monitor disease progression, and also what happens in systemic diseases. So what is IVCM? So it's in vivo confocal microscopy of cornea. We've got HRT2, HRT3 Rorschach corneal module, and it visualizes the cornea at a cellular level, and it is a non-invasive tool. And the size of these images are 400 by 400 microns, and it only takes about a couple of minutes to scan. However, if you want to create a montage or a nerve map, that takes a bit longer to scan the whole cornea. As I mentioned, it scans the cornea from epithelium, so it's layer by layer. So you've got from wing cells, you've got basal epithelium, subbasal nerves, and anterior mid deep stroma, and of course endothelium. So we've looked at subbasal nerve plexus closely, a number of groups all over the world, and this is one of the main measures that layers we look at, and there are multiple measures. So it's neuroma, stochasticity, beating, reflectivity have been reported, and What we also look at, most importantly look at, is south-basal nerve density, and that's the most repeatable one. There are multiple tools. They're automated, semi-automated, manual, but the nerve density is the one that can be repeated in most diseases in health. What we use, so it's Neuron J Image J. This is semi-automated, and you trace the corneal nerves with the support of the tool, and it automatically transfers and calculates the mean density. So as part of my Fulbright Fellowship, I went to Johns Hopkins, and we have developed another tool, an automated tool, using deep learning-based methods, and we're also working to look at these maps as well. So as you can see, this was done as part of my PhD some 15 years ago, and I had to manually spend hours in using this jigsaw puzzle. But as I mentioned, we're working towards making this more automated, so we can use it in a more clinical settings. Endothelial cell count, so in the scanning we use this measure quite a lot as well. Of course, there is specular microscopy now, that's in most clinics, it's available, so that can be done quickly as well. So what happens is that this one as well, it can be fully automated, semi-automated, or manual method. I'd like to briefly mention about slit scanning confocal microscope. We still have it, and I did use this also for my PhD, and it is a contact procedure, but it does show excellent images of endothelium. And as published by Patel and McGee, you can make it, it's very simple to just feed in and use the automated analysis, or just with manual adjustments, you can just get more detailed analysis. What happens in disorders and after surgery? So again, Patel and McGee published this over 2 decades ago. So this is normal corneal nerve plexus, and you can see how they, on the side, they create like a nice anastomosing network, and that's a vortex region. But in keratoconus, that's not the case. And where are the nerves sitting? When we superimpose them with the maps, with the corneal topo maps, they tend to just hang around the base of the cone. After collagen cross-linking, you can scan the cornea before and after, how they progress, and you can see this lovely honeycomb-like appearance in different layers and in different time points. In Fuchs dystrophy, of course, we've mentioned a few times about Fuchs earlier, and in confocal microscope, you can see these impressive guttete, and you can see that in confocal microscope as well as in specular as well. Of course, it's like the way they appear is quite different. And DSEC. So this is this publication by Akira Kobayashi, the Japanese group. And on this side, on the left, you have got these 3 images. This before corneal transplant, before DSEC, and on the right, that grid shows 3 months after DSEC, and how the nerves are starting to come back, and the endothelium is looking a bit healthier as well. What happens in penetrating keratoplasty? So another paper from our shores, Nietzsche et al., of course, way before PKP, how the nerves were in A, and 6 months after, how they're still trying to grow back. So it takes any time between 6 months to 5 years for them to grow back, really. And on the far end, you have got 2 images showing a graft, a 14-year-old graft and a 17-year-old graft, how the nerves, the stromal nerves, are getting back in shape. And this one is stromal lenticular adhesion keratoplasty. You can see in different grids. So the first grid, you've got the first panel is after 1 week, 1 month, and 3 months after surgery, how the nerves and the stroma is looking like. another few, ELAC and FLAC, and I'm sure if there were several techniques mentioned by Dr. Fogler earlier, I'm sure if we do all the confocal in those patients, it'll show interesting images as over a period of time. And you can see in D, you can also, the inflammatory cells in the interface and epithelial cells are also visible in there. And in this one, we've got so corneal nerves in fuchs dystrophy. That's we've got an A and E, and after keratoconus, you've got NB and F. So you've got different panels in different diseases. How things look slightly different in stromal nerves in around the graft-host junction zone. What happens when we look at in different diseases, so cell types, you can visualize different cell types. So in A, in the top left corner, you can see leukocytes, so these are hyperreflective greasy cells. You can see, and on B, so those are blood corpuscular elements in vascularized cornea.
Don't worry, another 3-4 minutes.
I know it's quite a shock to the system. So yeah, and I was saying, so they've got the blood, so it's quite interesting to see. When you're actually doing confocal, you can almost see them moving. And it's really fascinating to see the way they move. And I've shown it to my students as well, and they always get excited looking at moving blood cells. And you've got erythrocytes on the far end, and there you've got some Langerhans, some dendritic cells as well at the bottom in cornea and conjunctiva, you can visualize. You can also see phases of corneal ulcer. So you've got your progressive stage, A and B, and in the middle you've got regressive stage, and far end you can see the healing stage as well at different time points, how it's healing. So again, it can be used as a tool to just look at the cornea at a cellular level. Acanthamoeba keratitis, of course, it's one is quite common in India. And you see these cysts. So this image is actually using a slit scanning microscope. And this one is in your laser scanning microscope. So you can see the difference in quality, but nonetheless, you can see the double-walled cyst with the bright center in both cases. Just a brief mention about meibomian glands. You can also scan meibomian glands, and a lot of groups have done this as well and published on that. And lastly, I'd like to talk about just how this confocal microscopy can be used as a tool, so for peripheral neuropathy marker. And we have assessed, we have done several research studies on different diseases. So this one is from my PhD again. This is from between diabetes and healthy controls we looked at, and you can just visually see how the nerves are quite different. In Parkinson's disease, of course, there is a lot of dry eye, but I'm not going to talk about that. But in nerves as well, you can, again, without doing any special image processing, that it is quite different. So this one, again, I'll mention about SIV. So that's a simian immunodeficiency virus. You can see I'm actually scanning a monkey cornea. This is, again, part of my Fulbright scholarship in Johns Hopkins. And they are definitely sometimes well behaved as more than humans. Yeah, I did have a vet on hand. But so we showed them how they change after SIV as well. So there are not many studies done on HIV as far as I know, but yeah, we've done that in monkeys. Chemotherapy-induced corneal changes, we have seen, so we assess patients before and after and through their chemotherapy cycle, and we published that a couple of years ago as well. Again, we have ran out of time, but there are several other diseases as well that show inflammatory cells on corneal as well. So we did look at confocal microscopy of cornea and different types of it. Yes, it potentially can be used as a diagnostic tool, but of course not by itself, potentially in combination with other tools so you've got in clinic, definitely for research, and to monitor diseases, different diseases, including systemic ones. Thank you.
Great, thank you. Any questions for Dr. Mizra?
Ma'am, I want to ask, like, for dry eye disease also we can do that, no? Like, the nerve density, what you have shown in the confocal microscopy, what are the other uses which we can do in clinical practice? Like,
So dry eye, so you mean, yes, for dry eye disease, I didn't mention in this one, but there are several studies that have shown that there are changes in corneal nerves in dry eye disease, in Sjogren's syndrome as well. And yesterday I attended a talk by, I think Dr. Srinivasan, who is shown in SJS as well. So you're asking other assessments other than IVCM?
yeah, I'm asking like in the severe type of dry eyes,
Yeah.
where there is chronic inflammatory reactions, and Shermer's is like 1, 2, like that, or it's very severe going on, like as you told, SJS or any other conditions like that. So in such conditions, if we screen the corneal nerves in the confocal microscopy, it is like, or neurotrophic keratitis or something
Yeah.
like that. We can.
I'm sure, yeah, absolutely. I'm not aware of any specific studies that has used SJS as like SJS patients and used this as a tool, diagnostic tool. But I know there are a couple of papers on that topic.
But it is not like being used.
Not in a clinical setting, not that I'm aware of. No.
Okay.
Yeah, but potentially, I'm sure it can be used.
Yeah. So it's the setting of the. In India, I'm asking.
Yeah.
The whatever confocal microscopy what we have.
Mm-hmm.
Do we have this?
Absolutely. Yeah, this is done in HRT2, HRT3. This is what I'm sure I'm aware of. That's available at LV Prasad and Madurai as well, and even at AIMS, I know there is one, and
So
at
this
Dr.
setting
Shroff's
we
there
can
is one.
use in all what diseases
Correct.
you have told, like in
Correct.
diabetes also you have
Correct.
explained, and all variety of diseases, many variety of diseases you explained.
Yeah, yeah.
So all that we can use to like
Absolutely.
judge
Mm.
how is the clinical improvement of the
Absolutely.
patient.
So yeah, just to see on layer, like of course there is that clinical judgment that you have to make, but of course if you want to look at on a cellular level, definitely you can
So
do that.
how many, like it should as you have shown in the diagram
Mhm.
that
Oh, that's
that
the map?
that
We
map-
don't do the map all the time. It's only the central cornea. So if you have to pick two regions, you'd use the central and the inferior center where that the vortex is. So that's the anastomosing network I was saying. So those are the two regions, center and inferior center. You can use, and also if there is a specific area of interest. So if you know that this is where you've got, if there's a xanthoma keratitis, you can see it's mid-periphery. So you have to, of course, scan that specific region if you can see that on slit lamp.
Okay, so these are the areas which we have
Yeah.
to focus.
Yeah, you can scan any area, really. You can do any, so it's, but generally, if you want to do it quick, in 2 minutes, you just use central and inferior center, I would suggest.
So, like for example, if there is the corneal transplantation which is being done, and the
Yeah.
nerve density is increasing, and it's it's completely coming to normal. Such cases,
Yeah.
Are there lesser chances of rejection, or it's not related to that?
Well, that's a very good question.
I don't think confocal
Yeah.
is telling us anything about rejection.
Yeah, no study done
I
as far
wonder
as I know.
though, Suti, you were talking about the eye being the window to the soul, really, like these systemic diseases like Parkinsonism and things, and diabetic peripheral neuropathy, etc.
Yeah.
How common is it now to be used? Is it becoming common? Is it still mainly a research tool?
It is, can't say it's becoming common, but it has a lot of centers, I am aware, in India have that, and they do tend to use it, not regularly in clinical settings, primarily in research, but I think with centers with research interest, they use that in clinical as well as clinical setting.
Yeah, so that was going to be my point as well. I mean, confocal's been around for a long time, and it's kind of, I don't know, in most places they never seem to make that leap into clinical. And one of the issues is that now these machines aren't available. So I mean, we have one, we have a couple in the clinic, we have a couple in the animal facility, but Vostok don't make them anymore. So, so if you have it, I'd look after it and find somebody who can repair it. 'Cause that's what we've had to do as well. Just a comment on your this beautiful montage of pictures you showed of the stitching together. There is Oliver does have a wide field confocal device as well, which will take multiple images at the same time, and hopefully we'll be able to get this in Singapore. But again, it's not available for sale, and to me it's still a limitation that actually there's no company now currently, if anybody wants to go and buy one, you can't actually buy a machine.
You can't actually buy
So,
one, that's
yeah.
correct, but I understand they're developing something which is non-contact. That's why they have today taken everything off market, but who knows, it'll take a year, 2 years, or 5 years, or 10.
So,
but
their argument has always been this, they keep on saying there's no market. This is what they keep on saying.
Yeah.
So there's a lot of clever Indians, engineers. I would suggest somebody in India or China just develops a confocal for half the price and you have a market. Bring
Oh,
it to APO,
absolutely.
you get a market, I'm sure.
yes, of course.
One of the other problems is interpretation of FOC that takes a lot of. So in the future, I think if you have diagnostic devices with AI integrated, where the image that's captured is deciphered by the machine,
Yeah.
then maybe the clinical use will
Go on.
increase. Because right now the thing is, whether it's a fungal filament or whether it's a corneal nerve,
Yeah.
it takes an experienced user to figure out
Yeah.
what the difference is.
Yes, as I mentioned, so that we are trying to work with American counterparts to develop something automated. But other groups, including Malik's group, they have developed and still working on AI-supported tools to do the same. So how long that takes.
Yeah, because for looking at corneal microbiology, what you do corneal staining, now you have AI based, so the interpretation of what you see on the direct stain on microscopy, even AI can pick up with great
Yeah.
accuracy what you do with a human this thing.
Yeah,
So that
absolutely.
automates things and makes it better.
Yeah, definitely.
Okay, great. So I'd just like to thank all the speakers for their excellent presentations and the audience for participating in all the discussion. And so we'd like to close this session and wish you all a pleasant meeting at APO and AIOS. Thank you. Thanks, everyone.